Dr. James Amos, and I'm a consulting psychiatrist at University of Iowa Hospitals and Clinics in Iowa City, Iowa. And this is yet another geezer video. This time it's the Dirty Dozen on decisional capacity assessment, otherwise known as assessing competency, although there's a subtle difference between assessing decisional capacity and assessing competency. And we're going to go through that. So I've got about a dozen slides again. And if you're watching this on YouTube, you are certainly welcome, and I'd urge you to come to my website, The Practical Psychosomaticist, in order to see the whole show, because there'll be a set of slides there, and most of them annotated, explaining in detail what I think is the proper way to conduct a decisional capacity assessment, and how and by whom it's best done. So let's go through the slides. I'm going to work with my laptop here and go through each one. We'll start with slide 3, because that's where the business starts, distinguishing between capacity versus competence. So capacity is the ability to accept or decline treatment, and it's determined by a clinician based on the patient's ability to demonstrate specific knowledge about certain features that I'm going to discuss. And it doesn't always have to be done by a psychiatrist. The issue of competency is that it's a legal definition, and that's established by the courts. A clinician's recommendations can influence a judicial ruling on competency, however. The law presumes competence unless otherwise proven. So slide 4 is relating to the abilities related to capacity, and they consist of the ability to express a choice, to understand relevant information about what you're recommending for your patient, to appreciate significance of information for one's own situation in light of one's own values, and to appreciate the consequences of those decisions. To also reason through treatment options is yet another ability related to decisional capacity. Now, slide 5 discusses when to assess capacity. And there are times when you should think about assessing and reassessing decisional capacity, and that can be when there's an abrupt change in a patient's mental status. It can happen when there's a refusal of recommended treatment, especially if the unwillingness to discuss the refusal seems difficult for us to understand and seems related to misunderstanding on the patient's part and apparent irrationality. You should also assess capacity, or consider doing that, when there seems to be an overly hasty consent to risky treatments. The presence of known risk factors for impaired decision making are also signals for when you should assess decisional capacity, and those are chronic psychiatric or neurological disorders, cultural or language barriers, and educational level concern, or age extremes, very old to very young. The next slide, slide 6, are questions to ask when assessing capacity. And these are really the nuts and bolts, and they're not that difficult. Questions about understanding include, what's your understanding of your condition or your situation? These are questions that you ask the patient. What are the risks and benefits of the proposed interventions and the alternative interventions? What are the consequences if nothing is done? Questions about appreciation. What do you really believe about your condition or situation? Why do you think the intervention is the best one for you, or why not? Questions to ask about reasoning. How are you weighing the pros and cons of the interventions as we've discussed them? And then lastly, there are questions to ask about expression of choice. We've discussed several options. What do you prefer to do? And those sound simple. In real life, decisional capacity assessments tend to be a little messy, and many times the issue is not whether or not you remember to ask all of these questions and to ask them in the right way, but the problem tends to be miscommunication about what needs to be done and why between doctor and patient. And those come up fairly frequently. The next slide, slide 7, is about capacity expectation thresholds. And really this is more about assessing when it's time to worry about someone's level of capacity. For example, when the risk of a procedure is relatively low and the potential benefit is high, say a blood draw for electrolytes. The capacity to make a decision about that doesn't have to be very high. So if the patient really doesn't understand all of the ins and outs about phlebotomy or blood draw, it's really not that important. And conversely, when the risk is high and relative benefit is low, you want to insist on a higher standard for level of capacity. Slide 8 is a slide about common pitfalls by referring physicians who request capacity evaluations. One of the assumptions is that the patient who lacks capacity for one task necessarily lacks capacity for all tasks, and that's not necessarily true in every case. There's also sometimes a lack of understanding that capacity is not an all or nothing black or white process. It's task specific and time sensitive, and it's best considered a process, not a one-time evaluation. Slide 9 is very interesting because it's a description of various reasons that purport to explain why there's an excessive rate of psychiatric consult requests for capacity evaluations. The sense I get is that these have not been subjected to rigorous research. These are probably recollections of psychiatrists who've been in practice for some time, and these are impressions that they have about the reasons why their colleagues request decisional capacity evaluations. And I'm not going to read them all to you. They're available at my blog site on the Post. One of them, the major misconception is the psychiatrist is often viewed as an informed consent technician, and there are several scenarios that can result from that, and one of them is the efficiency model, for example. So incompetence is presumed, and the psychiatric consultant is expected to remove legal barriers expeditiously to obtaining surrogate decision makers' consent. And there are a variety of others, such as pseudo-consultation, in which the consultee lacks patience, interest, or time to do the capacity assessment himself or herself. Try not to be put off by these scenarios. They're probably based in experienced psychiatric consultants' observations about many consultation requests of this nature. The next slide, slide 10, simply continues the description of scenarios about psychiatric consultants being thought of as informed consent technicians, and proposes a solution that's collaborative instead of transferring the responsibility for assessing decision capacity always to the psychiatric consultants. Not in every case is that a wise idea. For example, in situations where a patient is expected to make a decision about a surgical procedure, one would expect that the surgeon is in the best position to evaluate or explain the risks and benefits of a complicated surgical procedure. And in that case, a psychiatric consultant can be helpful in concert with the surgeon to assess whether or not a primary psychiatric disorder is interfering substantially with the conversation. And also, we can be helpful in detecting subtleties and deficiencies in decisional capacity and identify treatable forms of emotional distress or psychiatric disorders that interfere with the patient's making sound decisions. Slide 11 is merely a summary slide, and it's capacity assessment in a nutshell. So the thing to do is to determine if the patient understands, appreciates, manipulates information rationally, and is able to indicate a voluntary choice without being unduly influenced by others, including physicians. You should view capacity assessment as a process, not a single point-in-time evaluation. It is important to treat impediments to decision-making, such as treating the medical causes of delirium, which can impair decision-making. And it's also important to consider involving other disciplines like neuropsychology, occupational therapy, and spiritual services. And then it's wise to clearly document the process. There are decisional capacity rating scales out there. They are copyrighted and some of them are costly. A couple of examples would be the Aid to Capacity Evaluation and the MacArthur Competence Assessment Tool, or the MCAT. These will help organize your thinking about doing a decisional capacity assessment, but you'll still have to make a judgment call about the patient's decisional capacity. The last slide, slide 12, is a list of references and resources that I found helpful for organizing my own thinking about decisional capacity assessment. I hope you find them useful as well. They are papers and links to posts that I've written about decisional capacity. And I think that's probably what I wanted to go over with you for today. I hope you find this useful. There will be a short quiz at the end of the post, and look at the time. My goodness, I've got to go to work.